of the, as I mentioned, it was, I always used to keep following these messages. And when I received one such invite, it was a really great, thrilling news for me. And thank you for inviting me. About fingerprinting, I won't go into too many details, but it's a kind of a relaxometry. We were doing relaxometry in the past, but the uniqueness of fingerprinting is we do simultaneous T1 and T2 mapping, and it's very rapid. So you get like the relaxometry values in a 15-second scan, and it's a new technique, and we are trying to apply it to areas, like it's a translation phase of into clinical practice. So I mainly do the genitourinary part. So at some point, like in the future, if we get a chance, probably I'll definitely introduce that concept.
Yeah, thank you. You could share your screen and go ahead. You are the host now. You could share your screen.
I'm going to. I think my screen is still not.
Just put your cursor on the screen.
Yeah, I think I'm just going to the screen.
Just put the cursor, then the pop-up would come from below. Share screen.
Can you see my screen now?
Yes, please go ahead.
Thank you. So once again, thank you, sir, for inviting me. So I'll be talking about the management of cystic pancreatic neoplasms. It's a straightforward topic, but it has become very complex these days, mainly because of the various guidelines. So I'll try to briefly talk about these various guidelines, and the main aspect is the emphasis will be on how a radiologist will change this management in any given case. These are my disclosures. We already looked at them. So the objectives of this talk will be I'll briefly introduce the cystic neoplasms of the pancreas, and then the bulk of the presentation will be on the various guidelines. And towards the end, I'll talk about the approach, how to manage an instantly detected cystic pancreatic lesion, and what to look for, and how to apply these guidelines in any given setting. Now, the reason I chose this topic is, especially in the US, we are doing more and more MR imaging for patients who come with abdominal symptoms, and when we do that, we incidentally detect like lesions and tumors in almost all organs. And one organ where we frequently detect is the pancreas. And with the improvement in the technology of the MR, we are getting more and more high quality MR exams. We are able to see more and more pancreatic cysts. And just to give you a number, in the year 2013, the SEER database, there are about 3.5 million pancreatic cysts which were reported in the database. So that's a staggering prevalence of 2.5% of the population, which is very high. And in general, when we try to look at modality-wise, on a CT exam, on an average, we see around two cases with pancreatic cysts when we scan 100 patients. When it comes to MR, the number is much more higher. 20 patients out of 100 who have MR will eventually have a cyst in the pancreas. So now that's problematic, because MR itself is by itself an expensive exam with very high copay in the United States. So that actually adds a lot to the healthcare when we start working up these cases with pancreatic cysts in a haphazard manner. Now, risk factors wise, patients who have a family history of pancreatic cancer or even pancreatic cysts are more prone to have them. And also patients with genetic abnormalities. There are some syndromes which have increased risk of pancreatic cysts. Best case example is the von Hippel-Lindau. In patients with diabetes who use insulin, there has been a report of increased incidence of IPMNs, and it has been reported to be as high as 45%. So that's another thing, especially with increasing prevalence of diabetes and with increasing use of insulin. That's another thing to keep in mind. The exact pathogenesis of that is unclear as of now. Why do we need to bother about pancreatic cysts? The main thing is the risk of malignancy. In the subsequent slides, I'll talk about the risk with each type of cyst, the risk associated with each type of cyst. But in general, the malignancy risk is very low. But as the size increases, the risk of malignancy goes up. And the first attempt to actually come to a more comprehensive and more like nuanced way of interpreting pancreatic cysts was done in 2006 by the International Association of Pancreatology. It was done in Sendai, which is a place in Japan, and therefore the criteria for that were called as the Sendai criteria. And once these criteria were proposed, interestingly, instead of decreasing the number of surgeries, actually the number of pancreatic surgeries went up by nearly 200%. And roughly there are around 15,000 resections for pancreatic cancer, which are done in the United States, not cancer, sorry, for pancreatic cysts each year, but many of them actually may not need surgery. And the main challenge in this setting is whether we should either follow them, or should we resect them, or should we just let them leave alone. So, and many of these are because of the uncertainty of the behavior and also the increasing detection on the scans which we do for other reasons. Because of that, there have been guidelines which have been proposed for both surveillance and for resection. And again, the problem here is there are several associations: the American Gastroenterology Association, the IAP, which is the International Association of Pancreatology, then the European group, and then even the American College of Radiology. So all of them have come up with their own recommendations, and that is also a little bit contradictory, but with some of the guidelines recommending surgery and some not. But there are some areas where there is some common ground. So overall, I think there is still a role for improvement. And in the subsequent slides, I'll try to talk about the discrepancies and the disagreements between these various guidelines. Now, classification-wise, we all know that cystic pancreatic lesions are very heterogeneous. Even a pseudocyst is technically a cystic lesion, but it's a pseudocyst, as the name indicates. But the common ones which we can encounter in the clinical practice are the serous cystadenoma, the mucinous cystic neoplasm, and the IPMN. The rare ones which we maybe see sometimes are the SPEN, or the solid pseudopapillary neoplasm, and then the acinar cell carcinoma. Few other rarer tumors like lymphangioma, hemangioma, and paraganglioma can be seen sometimes, and can be, like especially the paraganglioma, can be cystic in few cases. And there are a few other scenarios where you have a solid lesion which has some cystic change, and then there are some really true epithelial, cystic lesions like the true epithelial cysts. Now, here you see that I have highlighted few of them in the yellow color, and the highlighted ones are basically benign and they don't need any workup. But you can see there are quite a number of names which are in the white, which may need some workup and need some kind of management. Moving on to morphologic classification, this is pretty straightforward. When it comes to a cyst, either it's a unilocular cyst, or if it's multilocular with microcyst, or multilocular with macrocyst. So these are the main categories. And again, if you see that there is considerable overlap, you can see that the serous cystadenoma appears in both the unilocular and multilocular group, and the IPM and MCN, they tend to appear in both the unilocular and the multilocular group. So morphology-wise, though it's helpful in many cases, there are instances where even morphology may not help much. So I'll briefly go over the most common types of the cysts, just to understand the guidelines. We might have to know a little bit about their imaging features. Now, this is what we have: the serous cystadenoma, then you have the mucinous cystic neoplasm, the SPEN, and then we have the IPMNs, both the branch duct and the main duct or the mixed duct IPMNs. So first, going into most benign and the least malignant of all, or practically no malignancy, is the serous cystadenoma, which is one of the, if you all remember from the residency days, the classification of the pancreatic cysts, we know the daughter, mother, grandmother lesion. Serous cystadenoma is a grandmother lesion in the sense that it typically happens in elderly women and has a very characteristic appearance. You can see here in this case, tiny cluster of cysts like grapes, which are clustered together. And on the post-contrast images, you can see in this patient, there is enhancement of those septations. When you see this kind of appearance, you're almost certain that you're dealing with a serous cystadenoma, especially in an elderly female. And unique feature of serous cystadenoma is it typically happens in the head of the pancreas. My surgeon never believes me when I try to make a diagnosis of serous cystadenoma if I see it in the tail. But here is one such example. This is a patient with a serous cystadenoma in the tail, and the unique feature here is the presence of central calcification. And it's a bit hard to appreciate, but there is some central scar which is showing some calcification. Now, these are the classic features of a serous cystadenoma, and when you have these features, you're almost certain that you're dealing with a serous cystadenoma. And as I said, serous cystomas are almost always benign. The only reason you might have to operate on them is if they grow in a size, and because they happen predominantly in the head region, they may cause biliary obstruction, and that's when you may have to intervene. But most of the times, if you are able to make a confident diagnosis of serous cystoma, you are probably sparing the patient a surgery, at least in the right away. He doesn't need a surgery. Moving on to mucinous cystic neoplasm, this is a mother lesion. These are cysts which have a relatively higher malignant potential when compared to the other cystic lesions, and the malignant potential can go up to 1/3, like 1 in 3 can be malignant, and therefore these need more close management and may need surgical resection in many cases. In contrast to the serous cystoma, these typically happen in the body and tail of the pancreas, as in this case. 75% of the cases happen in the body tail. Again, just to throw a curveball, I have put in a case where the mucinous neoplasm actually was seen in the head. So again, just to keep in mind that the locations or the position is the location of the tumor in the pancreas is not always is not always going to help with the diagnosis. Few instances they may happen in other areas. So from morphology point of view, these are usually unilocular, or they tend to be, if they are multilocular, they usually have macrocysts. The individual cysts are not small like we saw in serous cystoma. The individual locules are pretty large, and they actually have a number for that. Usually the number of locules are less than 6, and the individual locules are usually more than 2 centimeters in size. So these are usually macrocystic if they are multilocular, or they can be unilocular. Now, the calcification, as I mentioned in the previous, in the serous cystoma, they tend to be central, but in the mucinous cystic neoplasm, they tend to be more peripheral. I don't have a CT image, but when you see it, it happens in the periphery of the cyst in contrast to the central portion in the serous cystoma. The unique thing about the mucinous neoplasm is that it shares some of the histologic features of ovarian mucinous tumors. That's very unique, and this is actually one of the differentiating features with IPMNs, which are also mucinous, but they don't have this ovarian type stroma. So that's a unique histologic hallmark of the mucinous cystic neoplasm. Now, this is a busy slide, but I'm trying to share, have a lot of information on the IPMNs, because these are the most common incident-related cystic pancreatic lesions, and also some of the most commonly resected pancreatic neoplasms. In spite of the guidelines, a good number of these undergo surgery because of the uncertain behavior. Typically, they occur in males in the elderly age group, and because of their ability to produce mucin, they tend to block the ducts, and which should result in duct dilatation. So based on whether the duct is dilated or not, they can be main duct type, branch duct type, or the mixed type. And there is some subclassification in pathology based on the MUC gene expression, which is a mucin gene expression. But at radiology, we can't really make differentiate those subtypes. Now, the key thing to remember with IPMNs is that in contrast to, say, serous cystoma and mucinous neoplasms, where they're usually solitary, IPMNs typically are multifocal. And as you can see here, more than like 1/3 of the cases have at least 2 IPMNs or more. And the reason for that is usually IPMN is a field defect, in the sense whatever pathogenesis results in IPMN doesn't restrict itself to one portion of the pancreas, but it tends to affect the whole pancreas. And because of that, there is usually multifocal. So if you see a cystic lesion, I think always try to make an attempt to find another cystic lesion, because that might probably help you in making a diagnosis of IPMN. And similar to the mucinous cystic neoplasm, the IPMNs are also frequently seen in the uncinate. And some of them can have calcification, and that's when you start getting worried about malignancy in them. Now, this is an example of branch duct IPMN. The main hallmark is a cluster of cysts which are closely packed, but they are not microcystic like we saw in the serous cystoma. And the most important finding which you need to find out in these cases is the duct communication. So if you see a cystic lesion and demonstrate a duct communication, unless it's a pseudocyst, you are sure that you're dealing with an IPMN. Like in this case, you can see a small communication here with the duct. The duct in here in this case is not dilated. So a cystic lesion which is communicating the pancreatic duct without associated pancreatic duct dilatation is the definition for a mucinous branch duct IPM, and the malignancy potential in these is around 30% on the higher side. Now, in contrast, when it comes to the main duct IPM, and these are usually pretty obvious. So like in this case, this is an MRCP image. This is a thick slab MRCP image, which shows a diffuse, like a dilated pancreatic duct. It's actually even difficult to know which, if this is like a single cystic lesion or a duct, but you can see that it's dilated along its entire length. And the dilatation is at least 2 centimeters in diameter. And just if you pay close attention in one area, you can see this like heterogeneous T2 signal area, which actually shows some enhancement on the post contrast. There is another such area in the lower down, which also shows like enhancement. And if you pay close attention here, you can see that the duct is actually opening into the duodenum, and it's a very wide opening. And this is what is seen at endoscopy as a fisheye appearance. So when the gastroenterologist goes into the region of the ampulla, they actually see mucin exuding from the ampulla, and the opening is so wide that it looks like a fisheye. So that's a hallmark of a main duct IPMN. So when we see that on imaging, I think it's a given that these patients should undergo surgery, and because the malignant potential can be 100% in these cases. There are some caveats when it comes to main duct IPMN. Many times we get confused with chronic pancreatitis, where there can be duct dilatation, but I'll go into that a little later. A quick word about the mixed type. It's basically nothing but a branch duct IPMN with associated dilatation of the main pancreatic duct. So these are 2 different examples. So this patient has a huge multiseptated cystic lesion, which is causing some biliary obstruction because of mass effect. And in addition, the pancreatic duct is diffusely dilated. Same another patient with diffuse duct dilatation and a cystic lesion in the head and synod process. So when you have a combination of an IPMN with the duct dilatation, we label it as mixed type IPMN. And the reason for that is the malignant potential of this is a little higher than a regular branch duct IPMN. And the dilatation of the duct should be at least 5 millimeter or above to call it a mixed type IPMN. Now, a quick word about SPEN. This is not seen as frequently as we see the other cysts. It's also called as a Hamoudi tumor. And the risk of malignancy is pretty substantial when compared to the serous cystadenoma. So inevitably, when we make a diagnosis, the patients undergo resection. And one reason is because of its age group. It happens in the young women, and therefore this is the classic daughter lesion. And because of the age at which it occurs, most of the times surgical resection is the best treatment option for these. And the classic hallmark is that they are usually large tumors with a lot of heterogeneous internal components with both hemorrhage, as in this case, this is a T1 weighted image, which shows high signal. So this is hemorrhagic or proteinaceous material. And posteriorly, if you see on both the T2 weighted and the post-contrast images, there is some heterogeneous T2 high signal like septations kind of thing, but on post-contrast, it has more solid enhancement. So when you have this kind of appearance in a young patient, it's almost given that this is a SPEN or a solid pseudopapillary neoplasm. Now, moving on to not the real cysts, which are the pseudocysts. Most often you get the history of prior pancreatitis, and then during follow-up, you see a cystic lesion in the pancreas. And the cyst usually has some layering debris in it, as both these cases here, there is some layering T2 hypointense material, which gives away that this is a sequela of pancreatitis, and this is the result of pancreatic inflammation atrophy. CT helps in these cases, mainly because it demonstrates the calcifications. Like in this case, you see a very nice unilocular cystic lesion, but when you look at the CT, you have this foci of calcification. Now, can this be a mucinous cystic neoplasm? Yes, it can be, but this patient had a history of pancreatitis. So we'll probably give the benefit of doubt. And there is severe atrophy of the pancreas, which doesn't happen in the mucinous cystic neoplasm. So this favors more of a pseudocyst. Now, there are a few instances, as I mentioned before, that it might be a little challenging for us to say if a patient who comes for an incidental, like a MR of the pancreas from maybe an outside institute, and then you do the MR, and this patient, this is an axial T2 weighted image without fat suppression, and there's a fat suppressed image. Main finding here is there's a diffuse pancreatic duct dilatation, numerous side branch dilatations, and there's not much other than that. So can this be a main duct IPMN? could be the duct is not as much dilated, but definitely there is, when you look at this case for the first time, you always have a little bit of hesitation, but once you try to look at the CT, it's a big giveaway, because you see the CT shows dense calcifications, which are practically not seen on the MR. In hindsight, you might see a few hypointense areas here and there, but this is a densely calcified pancreatic duct. And what we are seeing is a sequelae to chronic pancreatitis with several introductory calculi. So just a quick, one thing to keep in mind is always try to look for a CT scan if available to pick any calcifications, which might be very difficult to pick on the MR. Now, before we jump onto the guidelines, the one entity which has been challenging for me, like many times, is a cystic pancreatic neuroendocrine tumor, which is a challenge many times because as in this case here, this is not like a pure bright cyst, but on the post-contrast images, you can see that it's a totally non-enhancing lesion in the tail of the pancreas. And this actually turned out to be a cystic neuroendocrine tumor. The only, I can say the only place where, only sequence where it helps is the post-contrast images. If you pay close attention, you see a peripheral thin rim of enhancement. And that's one thing which has helped me sometimes to make the differentiate these tumors from like a IPMN or a pseudocyst. So just to keep in mind that this entity exists, and when you see this kind of peripheral rim of enhancement, and if it's not like a real bright cyst, you might have to think. I have a subsequent, there's one slide where I'll try to negate even this, where it becomes very difficult to diagnose even a cystic lesion. Last but not least, cystic pancreatic metastasis, very rare, but again, another case from personal experience. A patient with history of synovial sarcoma had this cystic lesion in the tail of the pancreas, which initially was thought to be like an incidental cystic neoplasm, but over a period of time, it continued to grow in size. And then you can see it started showing some solid component anteriorly, and post-contrast images started showing some nodularity. This actually happened over a period of 6 months. So from the first scan to the last scan, the impression was totally different. Now we think this is definitely a metastatic lesion. So chronology is important. Trying to look at previous scans and trying to understand the history of the patient will help you in many cases when it comes to diagnosing a cystic pancreatic lesion. Now here I have a trivia just to make it more interesting. This is a patient, as you can see, have the T2-weighted images and then the post-contrast axial images, mainly focusing the pancreas and the kidneys. Main finding here is numerous T2 hyperintense lesions throughout the pancreas. Almost the pancreas is totally replaced by cysts. And then same thing in the kidneys, you have like numerous cysts, some of them showing some septations, one of them actually having a T2 dark signal. And the post-contrast images, the pancreatic cysts do not show significant enhancement, but yes, I see the answer already from Ishwar sir. You're right, sir. So the finding is on the post-contrast images, you see some solid renal masses. And this patient also incidentally has a brain MR and a spine MR, which shows these tiny dots. And these tiny dots are nothing but hemangioblastoma. So this is a case of von Hippel-Lindau. So sometimes we tend to see these cases once in a while, not very common, but when we see it's usually a nice case for the residents to look at all the head to toe findings in von Hippel-Lindau, and it's a nice teaching case when it happens in the reading room. So just to summarize the cystic pancreatic neoplasms, the key finding is to know which are going to be malignant. As you can see, the serous cystadenomas, practically no malignancy. The rest, I think the variable malignant potential. And based on the age of presentation and based on the kind of appearance, say whether there is duct communication or whether there's solid component, you can come to a reasonable diagnosis in many cases. But having said that, there are instances where it becomes really difficult. Just to briefly recap the malignant potential, the mucinous cystic neoplasms, nearly 40%, branchial IPMNs, nearly 30%. The mixed and the main duct IPMN relatively higher, can go up to 100%. And then the SPEN and cystic neuroendocrine tumors, relatively low, but still some potential malignancy. So the main, as I mentioned before, the most common cystic lesion which we see during practice is the branchial IPMN. And so the emphasis in that on these subsequent slides will mainly on that. So the risk of chance of this transforming to malignancy is at nearly at the rate of 1% per year. Now, that's a problem because it's very low risk, but at the same time, nevertheless, a risk. And when it becomes malignant, the outcomes are very bad. Pancreatic cancer is one of those cancers where the 6-month survival is usually like around 5%, which means most of the patients die even before the next follow-up scan comes if there is a cancer. So it's very challenging to make sure these patients don't develop a cancer before they are caught. So now that's where we try to come up with some additional information when we can. In addition to CT and MR, which are the main workhorses, we try to take some cues on the CT and MR to do endoscopic ultrasound with FNA. These are done by the gastroenterologist. Especially this becomes necessary for cysts which are less than 3 centimeters in size, because we don't really know what happens to this. The ones which are more than 3 centimeters, most of the guidelines, they have a provision to do surgery, but when they're less than 3 centimeters, it becomes a little difficult. And that's where the EUS with FNA helps. And now this has become more and more streamlined now. Whenever a EUS and FNA is done by the gastroenterologist, the fluid is sent for analysis. And in addition to cytology, some biochemical analysis is also done, and that really helps many times. So when we do our multidisciplinary team meetings, this information is available for practically every patient who undergoes the EUS, because that basically tells us whether to do like a follow-up or just stop any further imaging in a patient. So if the cyst fluid has amylase, it basically means that cyst is communicating with the duct. And that happens if it's a pseudocyst or if it's an IPMN. So amylase positivity is usually indicative of most often pseudocyst. So if the cyst fluid has a amylase of less than 250, it's usually considered to be not a pseudocyst, and that needs further workup. Next is glucose. So usually glucose is like one of the metabolic, what do you call it? It's a the cancer cells use glucose for metabolism. So in a way, when the glucose levels in a cyst fluid are low, it means that the cyst is having some neoplastic component in it. And because of that, if the cyst glucose levels are low, and the numbers are variable, but the standard number used is 66 gram per DL. If the glucose level is less than that, then you start getting into the concern of mucinous neoplasm or an IPM. And those pseudocysts also have low glucose. But the more useful is when it's high. If it's more than 66, it's definitely a serous cystadenoma. So if you see a unilocular cystic lesion with a high glucose, no amylase, then you're dealing with a serous cystadenoma. Similar thing with mucin. Presence of mucin is usually seen with both the mucinous tumors, that is the MCNs and IPMNs. Now, a few other more nuanced and more finer tumor markers are the CEA and CA19-9. As you all know, CEA is carcinomembryonic antigen, and CA is again a carcinoma antigen 99. So both these are pretty indicative of a tumor. So both MCN and IPMN tend to have CEA and CA19-9 elevated. So when they do the cyst fluid analysis and they find these two, then there is concern that we are dealing with malignancy. Of late, there are some genetic mutations which are also being analyzed. If the cyst fluid has some cells in it, they usually send it for analyzing some of these mutations in KRAS, GNAS, and even I didn't mention it here, but the P53 mutation. So these are used to at least know if there is any malignant potential. So EUS with FNA is a very key component of the workup these days. And this is an article which we published last year, mainly looking at the various recommendations and to understand the complexity and to maybe put some sense into the various guidelines and to understand what each guidelines actually recommend. And this is one such table from this article. A lot of subsequent slides are mainly from that article. So as I mentioned in the beginning of the presentation, there are at least 4 major guidelines which help in guiding the management of the pancreatic cysts. The first one is the IAP, or the International Association for Pancreatology, then the American Gastroenterology Association. Then you have the European Society for Cyst Management, which is the most recent of all. And then you have the American College of Radiology, which is the 2017. The recommendations are from 2017. So each of these societies or each of these institutes has their own guidelines, but they have some. Each one was developed in a different way. Like the IAP and the AGA were based on a panel of gastroenterologists. The unique feature of AGA is it was only by gastroenterologists. There was no surgeon involved in developing the AGA guidelines. That reflects in their recommendations. Both the ACR and the European guidelines are more multidisciplinary and have more nuanced interpretation of this CIS. Now, the method of how these guidelines were developed is also interesting. The IAP were developed through consensus, like you have an expert panel who vote on various recommendations. Whereas the remaining 3 guidelines, they were developed in a little scientific manner. They used what is called as a grade method. GRADE stands for graded recommendations, assessment, development, and evaluation method, which is like a more scientific method, where they review the existing literature, and based on the literature, they come up with specific recommendations for specific entities. In contrast, the ACR recommendations are more like an expert opinion. A group of radiologists came together and wrote up a white paper, and that is used as a way to help us in the reading room in guiding in mentioning the recommendations. Another unique thing is surgical risk stratification. All the guidelines provide specific criteria where surgery needs to be done, except the AJA. As I mentioned before, the AJA guidelines were mainly developed by gastroenterologists, and that's probably the reason they don't really mention when surgery needs to be done. Whereas the remaining 3 guidelines, they actually have indications where specifically surgery needs to be done. And all of them have some mention of features which are high risk for malignancy and therefore need surgical management. So I'll go into some of those things in the next few slides. Now, before going into that, how do we approach an instantly detected pancreatic, cystic pancreatic lesion? Now, these are the various things which we need to look at. I'll go into these in a stepwise manner. The first thing you need to look at when you find a cystic pancreatic lesion is its morphology and its location. As I mentioned before, location-wise, most of the IPMNs and the mucinous neoplasms tend to happen more often. The mucinous neoplasm tend to happen in the tail, whereas the serous tumors tend to happen in the head region. But there are always exceptions. When it comes to morphology, for cysts which are up to 3 centimeters, it's usually difficult morphology assessment, unless there is a clear-cut pancreatic duct communication. But for cysts which are more than 3 centimeters, you can probably pick up some of these, whether there is septation, whether there is macrocyst, microcyst. These are usually possible for cysts which are more than 3 centimeters. In general, especially ACR says that if you see a cyst, unless you know that it's not a mucinous, assume it to be mucinous and treat it as a mucinous. And that's what reflects in most of these recommendations. And once we say it's mucinous, the follow-up becomes more intensive because, as mentioned before, mucinous tumors have more risk of malignant potential. We talked about the location already. So this is a quick flow chart of how to look at it. As I mentioned before, when you see a cystic lesion, just try to find out if there is any prior history of pancreatitis. If that is the case, then it's likely to be a pseudocyst. If not, then the next step is to look at the morphology. If it's a cyst which is big enough, say more than 3 centimeters, you can make out the micro and macrocystic. If it's macrocystic, it might end up being an MCN. If it's microcystic, it will be either a serous cystadenoma. If there is no communication with the pancreatic duct. If there is communication, it will be a branched IPMN. So this sounds very easy, but it's not always the case. It's very complex, as in how you take other things into consideration. One thing to keep in mind is how we measure the cyst. So I said 3 centimeters. Now, is it 3 centimeters in the axial plane? Is it 3 centimeters in the coronal plane? Again, when we do these reads, we try to be very consistent and make sure we measure the cyst in the same plane each time. And the most recommended way to measure it is on the MRCP measures. So you can take the thin or thick slab MRCP measures, preferably the thin slab, where you can take the longest axis, and you can either give the single longest or give 2 dimensions on this plane, and make sure you document the series name and number so that whoever is doing a follow-up uses the same kind of series and make sure that it's measured in the same way. And when we see a cystic lesion, we try to make every attempt to find additional cystic lesions because that will favor more of a field effect, which is the IPMN. And always when we see that, try to find if there is a duct communication or not. And if there is a duct communication, always measure the diameter of the duct because that's going to determine whether it's going to be a mixed type IPMN or a simple branch duct IPMN. Now, this is again a busy slide, but there's a lot of history to this slide. As I mentioned in the beginning of the talk, the Sendai criteria were proposed in 2006. Now, as I mentioned, the Sendai criteria were basically a way for surgeons to make a case for them to operate. So what happened was they came up with few criteria which they thought, when present in a cystic lesion, needs and is an absolute indication for surgery. Now, what are those conditions? If a cyst is greater than 3 centimeters, or if the main pancreatic duct diameter is more than 10 millimeter, or if the cyst has a mural nodules, or irrespective of this, if the patient is symptomatic, the Sendai criteria suggested that these patients should undergo surgical resection. Now, if you remember that when they used this broad criteria, it ended up in almost a 200% increase in pancreatectomies. And that was not the intended intention of this guideline. But it inevitably ended up being more trigger happy for the surgeons because whenever they see some of these, they ended up just doing the pancreatectomy, and that means more number of pancreatectomies and more number of post-surgical complications. Now, that's when few years later, they decided these criteria need to be more refined. And instead of directly sending patients to surgery, they wanted to make room for endoscopic evaluation. So they came up with two criteria. One is worrisome, the other is high risk. So when the mean worrisome, it means it's a cue that the patient should the next step in the management should be an EUS. When you say high risk, the next step is directly surgical resection. Now they try to tease out some of these things between the two categories. So when a cyst is just more than 3 centimeter, it's a worrisome feature. If it has a thick enhancing wall, or if it has a non-enhancing mural nodule, or if the main pancreatic duct is more than 7 millimeter, these are all worrisome feature. And the next step when you see any of these features is to recommend a EUS unless they have some of these features which are high risk. And the high risk features are presence of jaundice, presence of enhancing solid component, or a main duct diameter of more than 10 millimeter. So they try to further refine it, especially they try to make sure that not all cysts greater than 3 centimeter go for surgery natively. And they made sure these go into EUS. So this was a way to come up with a more nuanced way to interpret this cyst. Now, this is an example of a worrisome feature. So this patient had a cystic lesion in the uncinate process. This was a kind of a branch duct IPMN, but on the T2-weighted images, you can see that there is a tiny T2 hypointensity focus, also seen on this image here. On the post-contrast images, you don't see any enhancement. So now this is a non-enhancing mural nodule, and therefore, by definition, this is a worrisome feature, and therefore doesn't need surgery right away, but can be evaluated with the EUS. So this is what is a worrisome feature is, and it's a way to make it a bit more finer investigation of these patients. Now, this is a slide from table from the article which we published last year. Though there is a significant agreement in all the 4 major guidelines, there are some areas where they don't really agree, especially when it comes to the AJA. As I mentioned, this was devised mainly by the gastroenterologists. So they tried to tear off any of the commenting on any of the high-risk features which will need surgery. Instead, they just tried to focus on areas where they can think that there is need for endoscopic evaluation. In general, there is agreement, like any cyst, any main pancreatic dilatation of more than 10 millimeter is considered to be high risk and needs surgical consultation. A mural nodule of more than 5 millimeter, again, you can see that all 3 guidelines, they do say that they are high risk and need surgical consultation. So again, there are several other criteria which we try to look at and summarize in these different guidelines. And it's very exhaustive. And I think at any institution, we had to probably pick which guideline we want to follow or come up with our own guideline based on this, which is what we did. So the other things which we keep in mind about the incidental pancreatic cysts are growth. So again, it's the presence of growth has different definitions based on the initial size of the cyst. So if a cyst to begin with is less than 5 millimeters, it has to almost double in size to say it is growing. In contrast, a cyst which is between 5 to 15 millimeter, even if it increases by 50%, it's considered to be growing. Whereas for cysts which are more than 15 millimeter, even a 20% increase in size is considered to be growing. Now, I've purposefully avoided using the time frame in which this growth should happen, because there is right now no agreement. So no matter how many years, if any of this percentage of growth happens, it's considered to be a growing cyst, and that will trigger some additional evaluation, either EUS or surgical consultation. Multiplicity, we discussed this before. Whenever there is multiplicity of the lesions, it usually means a field defect, which means it's more likely to be an IPMN, which means slightly increased risk of malignancy. So just keep in mind to look at for multiple cysts. Now, the next few slides are going to be busy flowcharts. These are flowcharts which we derived from the guidelines in our article last year. So to simplify, I'll say that the easiest way to keep in mind is the branch point. So whenever you have a IPMN, try to look for high-risk stigmata. If there are high-risk stigmata, patient goes to surgery. If there are no high-risk stigmata, the next step is to look for any worrisome features. If there are worrisome features, patient goes to EUS. If not, then they go into a surveillance. And the surveillance is based on the size of the cyst. When it comes to the American Gastroenterology Association, as I mentioned, they don't really go into surgical dissection, indications of surgical dissection. Usually they try to stratify into high risk versus no high risk, and then just recommend either the patient needs to undergo EUS or needs to undergo surveillance. So they leave room for some surgical consultation based on the findings we see on the EUS. The European guidelines, I can say the most comprehensive of all, and the most, in the sense, the most accommodative have been the European. They tend to be, they really have been very careful when surgery is needed, especially in patients who they deem can be managed conservatively. They recommend follow-up for a longest possible time. They recommend actually a lifelong follow-up instead of being trigger happy and doing surgeries. So when there is no indication for surgery, they recommend follow-up based on initially they recommend every 6 months and then yearly. And keep in mind, these are for lifelong. These recommendations are lifelong. And that's something which is key to understand, because that means the cost of the patient care is going to go very high if the patient is going to get a lifelong follow-up according to the European guidelines. Again, these are very complex slides. I don't want to go into each and every branch point here, but the American College of Radiology has done an excellent job. The reason for that is, while the other guidelines are pretty generic, they don't take age into account, they don't take size, like much of size into account. The IAP does take size into account, but they don't really go into very fine size-based and age-based criteria. So the American College of Radiology, they actually start with age. The guidelines are, the follow-up recommendations are different when it's less than 65 versus patients who are 65 to 79. And they actually have a separate flowchart for patients who are more than 80. So, I mean, the follow-up recommendations you can look up at your free time, but the key thing is to remember when to stop the surveillance. So one additional good thing about the ACR is they recommend a stop date. They recommend stopping it at 9 or 10 years based on the size and age. And one thing to remember is that based on whenever the size increases during follow-up, they actually jump from one flowchart to another based on the new size during follow-up. And they have actually come up with a specific recommendations for patients who are more than 80 years old. And here they don't specify any time frame, because many of these patients are frail and may not really benefit from surgery. So the usual recommendation is just one follow-up or two follow-up, and then just stop at that point, because the management will not significantly change in the future. So because we are radiologists, I'll try to emphasize a little bit on the ACR recommendations. As I said, size is key. Age is also a key. The lesions will move from one algorithm to another based on the new size during follow-up. They recommend doing surgical consult or doing FNA similar to what I described before, based on worrisome or high-risk stigmata. Now, one interesting point which none of the other guidelines have recommended is a white dot lesion. So what are white dot lesions? So whenever we are looking at a pancreatic MR or any MR for liver or other organs in the upper abdomen, we see white dots in the pancreas. Now we don't know what to do with that. So the ACR has thankfully come up with a recommendation that when you see these white dots, the maximum we can do is maybe one follow-up at 2 years. Now there is a caveat to that, which is this. So there's one patient which I recently saw and like was really humbled by how cysts can really create a confusion in the management. So in the end, this didn't really turn out to be a bad thing for the patient, but this is a patient who had a double duct sign with a mass at the ampulla. You can see that even on the MR, and there is it's a very artifact ridden MR, but there is some enhancement in the ampulla. So this was the initial MR which was done, and then the patient underwent Whipple for that. But on the baseline MR, there was another finding which was you see this tiny dot here. This is a T2 hyperintense lesion in the tail of the pancreas. Now this was interpreted as a cystic lesion in the tail, which was thought to be like a dilated side branch or something like that. Could be an IPMN kind of situation. But since the patient had a more concerning finding in the ampulla, the patient underwent a Whipple. So when I reviewed at the tumor board, even I didn't realize that this cystic lesion could be something. In the tumor in the multidisciplinary team, we usually end up reviewing like 30 to 40 cysts. So in that, I definitely missed. I did see this cyst, but during follow-up after surgery, the patient, because he had the ampullary mass turned out to be a neuroendocrine tumor, underwent a gallium PET. This is a routine protocol in our institution that patients who have a neuroendocrine tumor at surgery will get a follow-up with a gallium PET. And this is a dotodate scan, and you can see that there is a brisk uptake of the tracer in the cystic lesion, which we saw in the tail. Now, when we go back and look at the post-contrast images, there is definitely a focus of intense enhancement. So what looked like a cystic was actually a cystic appearing lesion, but it's actually a solid enhancing lesion, briskly arterial enhancing. So this was like a very tiny neuroendocrine tumor, but management-wise, it didn't really make a difference because only this patient already had a more concerning tumor in the ampulla, and the surgical resection guideline for our institute for neuroendocrine tumors is more than 1.5. So tumors less than 1.5 centimeters don't undergo surgery. Neuroendocrine tumors of that size don't undergo surgery. So it didn't really change the management, but I think when you see a cystic lesion, it's important to look at the post-contrast images to make sure that it does not enhance. So one such caveat is for these white dot lesions. Now, I'll briefly talk about the two main things which can happen with a cyst, either resection or EUS with or without surveillance. So resection usually indicated for main duct IPMN or IPMN with high risk stigmata or a mucinous cystic neoplasm. EUS is usually recommended for cysts with worrisome features or more than 3 centimeter cysts without worrisome features. And if the EUS is inconclusive, the patients enter into the pool for surveillance. Now, this is a slide I took from a Nature review paper, which tried to summarize the various indications for surgery. So I've tried to like come up with my own way to analyze the table. So first for EUS, the individual guidelines, the AJA says any cyst of more than 3 centimeter or cyst with nodular pancreatic dilatation needs EUS. Same thing with the European guideline, but they say that you should do the EUS only if you think that it's going to change the management. And the recommendations are similar to the IAP. So before that, I'll probably go to the IAP guideline, which says that EUS is recommended for any cyst which has a growth of more than 5 millimeter in 2 years, or if the CA99 is elevated, or if the pancreatic dilatation is 5 to 9 millimeter, which is basically a worrisome feature, or a cyst of more than 3 centimeters, a cyst with prior pancreatitis, which is caused by the IPMN, or you have an enhancing mural nodule of less than 5 millimeter, or a non-enhancing mural nodule of more than 5 millimeter, and few other findings. So the difference between the IAP and the European guideline is that they recommend as EUS if the growth is more than 5 millimeter in 1 year, not 2 years. And in any patient with new onset diabetes mellitus, or the cyst is more than 4 and not 3. So there is the guidelines are somewhat similar, but there is some difference when it comes to the size cutoffs. Now, when it comes to surgical resection, as I mentioned before, the 3 main cysts are the serous cystadenoma, MCN, and IPMN. Again, by guideline wise, ACR recommends surgery for a SCN if it's symptomatic or if it's more than 4 centimeters. European guidelines recommend if it's symptomatic, that is if it's in the head and causing jaundice. IAP and AGA don't recommend anything for SCNs. They just leave it there. They don't make a specific comment on it. For the MCNs, it's interesting because both IAP and AGA, they recommend resection no matter what. So AGA doesn't say categorically that surgery needs to be done, but they imply in a way that surgery needs to be done. Whereas when it comes to the European and ACR, they have a size cutoff even for MCNs. They don't recommend surgery for all. And that sometimes reflects in the eventual cost, which happens when you follow the IAP versus the ACR. So the size of 3 centimeters is a trigger for surgery in ACR, whereas for the European guidelines, it's 4 centimeters. When it comes to the IPMNs, again, the common guideline in all the common indication for surgery in all is the presence of symptoms, which is jaundice or main pancreatic diameter of more than 10 millimeter. The other common findings are mural nodules. If there are mural nodules, then it's always an indication for surgery. The ACR says that the presence of a mural nodule is a worrisome feature, not a high-risk feature. And so according to them, when you see a mural nodule, it's sent to be, it goes to the EUS pathway and not the direct surgical pathway. And then the cyst size, almost all of them have a cutoff of 3, except the European, which has a cutoff of 4 centimeters. The SPEN and the cystic neuroendocrine tumor, they again undergo surgery, especially if there is a growth in the cystic neuroendocrine tumor. This next slide is about surveillance. Again, as I mentioned, the surveillance is different from each guideline to guideline, but the one thing is the AJA and ACR are time bound. The AJA guidelines recommend no follow-up after 5 years if there is no change, whereas ACR is 9 to 10 years. Both the IAP and the European guidelines, they are for lifelong, or as long as the patient is fit for surgery, the patient should be followed. The duration of follow-up and the frequency of follow-up, sorry, not the duration, but the frequency of follow-up is based on the initial size. If it's very small, like less than a centimeter, you can do it at more relaxed intervals. But if it's bigger size, you may have to follow more intensively. Now, what do we look when the surveillance scans? Things like change in cyst size, duct dilatation, presence of new mural nodules, or presence of new mass effect. A couple of examples. So this is a patient who had scans at first 6 months and then 1 year, almost all 8 months interval. So there is a focal dilatation of the duct, and the duct more distal to it is also diffusely dilated. This was in June of last year. And then in the February of this year, the degree of dilatation of that focal area is slightly increased. And on the subsequent scan, it's much more dilated than before, and there is more dilatation of the duct distally. So this was kind of a main duct IPMN, which was gradually worsening. The reason for normally this could have probably gone for surgery much more earlier, but the age of the patient was taken into consideration, and I think at this point now this patient definitely needs surgery because they're at risk of high risk for malignancy now and other complications. So at this point, I think surgery was decided that is necessary. Another example, a diffusely dilated duct with several dilated side branches. One follow-up at almost all 8 months showed that the duct was almost all stable. The difference in projections, it actually looks a little smaller, but during follow-up in May of this year, one portion of the duct started dilating more than the rest. And this is where we started getting worried that there might be some change in the morphology, and this triggered a EUS in this patient. I think he's probably still planned for surgery due to some comorbidities being still in the wait list, whether to do the surgery or not. But these are the things we need to keep an eye during follow-up scans. Now, this is the last 1 or 2 slides here. While the follow-up guidelines are pretty robust and they help in managing the patients accurately, you should also keep in mind the cost behind these scans. To simplify, there are few studies which have evaluated these guidelines. Most of them, the IAP, the AJ, and ACR have been evaluated. The European guidelines, they are the most recent, and not much studies have been done about their cost effectiveness. But when it comes to the IAP, in general, if you remember, IAP is more trigger happy in the sense there are more surgeries which have to be done. And because of that, the cost is a little high when you follow the IAP guideline. But in contrast, when you do the AJA guideline, because it's a short follow-up, there are more missed cancers when you follow the AJA guideline. Like there are 71 missed cancers compared to 49 in one study. IAP, on the other hand, will result in more surgeries and more imaging studies, mainly because it's a longer duration of follow-up. So you can see there is a flip. You have to pick between whether you want to miss cancers and decrease the cost, or you want to pick more cancers, more surgeries at a higher cost. When it comes to the ACR, in one study, they found that the average cost per cyst is basically per person was around $460. But again, based on the referring physician, if the referring provider really stuck to the ACR guidelines in following, the cost actually doubled. It went from $460 to $850. But if they underutilize the guidelines, they actually cause the cost actually halved. Now, this study didn't go into the missed cancers when they do that, but it's interesting that when you stick to the guideline, you're actually going to be more, following the guidelines comes with a higher price tag. You need to keep that in mind. Now, at our hospital, we have a pancreatic cyst clinic, and that's where most of these cases which I showed you actually came up. So we have a multidisciplinary team, which includes a radiologist, an oncologist, surgical and medical, and then gastroenterologist and a nurse practitioner. So what the surgical oncologist and this nurse practitioner, they practice is they use a natural language processing software to screen the CT and MR reports which happened during that week throughout the hospital. And they try to pick specifically reports which mention a cyst in the pancreas. So they pick those cases and then they bring it for the weekly meeting. And then we determine based on the images, which will need follow-up, which will need surgery, or which needs no further management. It's a very tedious job. As I mentioned, every meeting, we end up reviewing 30 to 40 cases like this, but sometimes it really changes the management in few patients. And as I mentioned before, the various guidelines, there is some contradiction between the various guidelines. So every institution should probably use their own guideline, which is basically based on these existing guidelines. Like in our institute, we try to come up with something which we try to modify the IAP guideline, and we mainly determine whether the patient is surgical or not surgical. If there is no surgery, then no more studies. But if the person is surgical candidate, then if there is high risk stigmata, he goes to a surgery. If not, we look for the worrisome features. Now, these are the places where the radiologist is key, whether picking up the high risk stigmata is one of the key areas where we help. And also for the worrisome features, these are fine findings which they cannot pick. Say a mural nodule, they cannot pick it. We probably have to be the ones who pick those small findings. So once we pick up those, the subsequent workup is based on whether there are if there are worrisome features, we do a EUS, and the EUS confirms like a definite high risk feature, then they go into surgery. Otherwise, they go into follow up. Again, at our institute, we didn't come up with a stop date for the follow-up. We just ended up saying no longer a surgical candidate. Again, this is not what the ACR follows, but again, we are a surgeon-driven program, so we probably were more following the IAP recommendations. So in conclusion, incidental pancreatic cysts are pretty straightforward many times, but they can be, there is always a diagnostic dilemma and management dilemma when it comes to the small ones. And usually the best care is provided by this multidisciplinary team. And using the guidelines should be very prudent. As I said, they come with a price tag, so we should be careful of what we are choosing. And one place I think which definitely helps us is that because of this complexity in the various guidelines, there is always scope for improvement. So that's I think in the future, there is a chance that we might further refine these classifications. I don't know if we have time, but just want to briefly mention that the University Hospital, our hospital is part of the CAPS consortium, which is a pancreatic cancer screening consortium, and we have patients who visit our clinic for high risk, who have high risk for pancreatic cancer based on genetic risk. These are different groups. I won't go into details, but there are both high and intermediate risk groups. And these patients, they have a separate clinic for the CAPS clinic where they are seen by gastroenterologists and surgeons to determine if they need to be followed. And that's where we came up with abbreviated MRI, which is basically MRI without contrast. We try to do the MRI without contrast. And there is one such patient here. This is a patient who underwent the abbreviated MRI. And we picked a very tiny lesion. This was like at surgery, it was a less than 1 centimeter pancreatic cancer. No duct dilatation yet, but you can see the cutoff of the duct. This patient had a history of familial atypical multiple mole and melanoma syndrome. And I think this is other picking up area we are trying to do, and more and more of these abbreviated scans. With that, I conclude. I might have gone a little bit over, but I'm ready to take any questions. Thank you.
Thank you, Dr. Sree Harsha. That's a fantastic presentation, highlighting the role a radiologist should also be playing as a clinician in trying to triage and manage these incidental cysts. So 2 questions from my side. We have gastroenterologists and surgeons are also on the delegates list today. So 2 questions from my side. If you detect a cystic lesion on an ultrasound, as an incidental or as a symptomatic, which one would you propose to do next, a CT or an MRI? Number 1. Number 2, any role for diffusion weighted imaging in differentiating between these various cysts?
Sir, yes, sir. So first question about incidental detector and ultrasound. I'm biased because I do more MR, so I'd say any given day MR would be my recommendation, mainly because MR gives you some finer additional details. As I said, the key for a cyst is whether it's communicating with the duct or not. And CT usually doesn't, many times doesn't help us in making that picking up the fine finding of duct communication. So I would say the next step should be getting a MR. And then about your next question, sorry, just remind me.
Diffusion weighted imaging.
Yes. So to be honest, so I towards the end of the talk, I mentioned the screening abbreviated MR. So one thing we don't do on that screening is diffusion. And the reason for that is we think that diffusion may not add in, it might help in picking up a lesion, but it doesn't help in further characterizing it. So most of the times for cystic lesions, we more often rely on the thin MRCP, the navigator sequence, but we use diffusion, but again, not for characterizing. Maybe if we want to like pick more lesions, we might quickly scroll through the diffusion weighted images. But I personally, I cannot make a differentiation based on diffusion between the various cells, because most of the information is available on the post contrast and the T2 weighted images.
Yeah, thank you. I have gastroenterologist Dr. Gopi Srikanth who would like to add anything. If not, there are a few questions in the chat box as well. Before Srikanth, yeah, Srikanth is there as a gastroenterologist with us from the AIMS group.
Hello.
Good evening, sir. It's a very nice presentation. And I want to know, how do you differentiate IPMN from CP? Like, if a patient presented with incidentally find dilated MPD, so can we how do we differentiate between main duct IPMN and CP?
Chronic pancreatitis.
That's a big problem. As I said, we encounter this situation many times where patient has no prior imaging, no prior history of pancreatitis, and suddenly comes up with a dilated duct. So one useful strategy would be to look at the atrophy of the parenchyma. Usually, as I said, again, there are exceptions. When it's a main duct IPMN, there is not as much atrophy as we seen as chronic pancreatitis. So for chronic pancreatitis to cause duct dilatation, it's basically fibrosis, which will result in stretching of the duct and dilating it, right? So the parenchyma should be really atrophic to cause that degree of dilatation to mimic an IPMN. But again, there are cases where I have seen where even a main duct IPMN in an elderly patient, because of the age, there is parenchymal atrophy and still the duct is dilated. So in those cases, that's where EUS comes into picture. So now that's where we use the worrisome and high risk stigmata thing. So based on the degree of dilatation, we can the EUS, if you get this fluid and it shows mucin, or one of those markers which I mentioned, it's going to be more favoring an IPMN. The calcifications is another feature. If there are intraductal calcifications, it's usually favored to be chronic pancreatitis related duct dilatation. And that's where having a CT helps. The one case which I showed where there were like dense calcification in the duct, just looking at the MR, it looked like main duct IPMN, but when we looked at the CT, it was clear it was chronic pancreatitis.
Thank you. And one more question, practically, like for which cases do the patients in your university undergo EUS?
Yeah, so especially for based on the algorithm which I showed you from our hospital, so first and foremost, if the patient is a surgical candidate, like if he has no comorbidities and he's fit to undergo surgery, we look at the imaging, and if it shows a duct dilatation of say like 5 to 9 millimeter, looks like an IPMN, or a cyst is more than 3 centimeters but doesn't have any mural nodule or anything which looks like is sure shot for a high risk feature, we send them for EUS. And one other thing which I didn't mention, I don't know if it's available in India or not. So we do a blood test which is called as IMRE, IMMRE. It's a new test which is developed by a company called Immunovia. So it's like a blood test in addition to CA99 and CA125. This is more considered to be, has a more positive predictive value in the sense if it's positive, then there is a high chance of malignancy. Negative test doesn't help. So IMRE is another test which we do. It's not on the cyst fluid, it's on the blood. In patients who have a cyst which is inconclusive on EUS, we also do IMRE. I don't think it's available in India. It's a new company which came up. So the IMRE is another test which are right now bringing into practice in patients where there is a diagnostic dilemma, whether we need to consider it to be malignant or not.
Thank you. Thank you so much.
Yeah. Any other questions with Dr. Jagan, Dr. Madhusudan Rao, and any others? Dr. Bhaskar?
Doctor, I have a few short questions. Like actually, in the talk you mentioned that in the CTs, in the earlier scan, the CT scan was showing only 2% and MRI was showing around 20% instead.
Yeah.
And why so much discrepancy is there?
It's the inherent difference in spatial resolution. I think MR, because of the availability of so many sequences and because of the T2-weighted images and the MRCP, definitely will like highlight the cyst much more easily than on a cyst, than in a CT. So CT usually, because of the majority of the CTs we do in US are standard portal venous phase. And in that phase, usually the distinction of the parenchyma from the cyst is, unless somebody plays very close attention, we are likely to miss more lesions on the, it's not that they're not there, but they are there, but we can't really pick them on the CT because of the way in which the scans are done. These are all incidentally like the portal venous phase images, which we try to run through in the ED setting or in the outpatient setting, and that's the reason we don't. And many times what happens with MR is, the reason why we pick more on MR is these are done for specific indications and we pay more attention to each and every organ there. And also, in addition to that, in general, MR is more sensitive, like in the sense for picking up the bright lesions.
Thank you. Regarding actually I saved out, I had like issue about the follow-up. You have given the answer, but I want to be more specific, like when we follow with the MRI, is it standard MRA or MRCP and contrast? Can you just
that's a very good question. As I was hoping somebody will ask me this question about contrast. So I told you about the costs, right? The cost for following a cyst is very high. It's like $460. That's like a rough estimate based on CMS, but when we go to private centers, it's much more higher. So there is a push to follow this cyst with non-contrast MR, because what we are looking mainly during follow-up is duct dilatation for increase in cyst size and maybe some mural nodule. All these three, at least the first two, we can see definitely on a non-contrast MR. The mural nodules may be a little tricky sometimes. So there is a push in some places to do non-contrast MRs for follow-up to decrease the cost. Unfortunately, at our institute, we haven't still been able to convince the surgeons. And as long as US, all the exams are insurance driven. So as long as the insurance approves, we get them done. And one of the reasons why we introduced the abbreviated MR was for that reason, because there are some patients who wouldn't get authorized by the insurance to get the MR. So we started the abbreviated MR, which is very cheap. We do it for $200 for the limited MR. So definitely, I think if given a day, I think if we do a study where we take out the contrast sequences and make some readers read the non-contrast only and see if they pick and find the differences, I think there will be good agreement both with and without contrast.
Thank you. Thank you.
There's
Nice-
one question
nice
from,
presentation.
yeah. Thank you, sir. There's one question from Kavita. How often
Yes.
do you do PET CT, FDG, or gallium in this whole algorithm?
We don't really use it in the cystic algorithm. We definitely use it in the neuroendocrine algorithm. It's like we do it very frequently for the neuroendocrine tumors. Unless there is a incidental neuroendocrine picked on one of the cystic lesions during pathology, like the case which I showed you, where there was neuroendocrine tumor in the ampulla, and during follow-up, the incidentally picked a neuroendocrine tumor in the tail. We don't have it as part of the cystic lesion workup, but definitely we do a lot of gallium scans for neuroendocrine tumors. It's a long process. We can definitely chat about it offline. I just saw a comment about how to become a radiologist in US.
Yeah. And it changes every 5 to 10 years, I guess, the whole
Yeah.
process. Yeah, I think. Yeah, Dr. Madhusudan Nagar, anything to add from your side? Yeah. Yeah, thank you again from KREST, Sree Harsha. That's an excellent thing for all of us. And one very nice thing I've noted is we got a reference for each slide so that we all could go back to those reference articles and access them for more details. That's a fantastic thing what you've done. And then you have all inspired us to become clinicians once again, be part of management protocols and try to assist the clinicians in going that. Thank you once again. Thanks everyone for joining us. We'll take a break for the new year and we'll meet next year. We'll continue the whole series. We look forward to your talk on RCC at some point next year, Sree Harsha. Best wishes for your research on that, and maybe we could chat more on MRA fingerprinting in some time later. Thank you once again. With all your permission, I would end the meeting.
Thank you very much.
Thank you. Thank you. Good day.